So it is an absolute pleasure to have this final wrap-up session. All right, I have not 4 psychiatrists on the couch here, all right? They are not able to deal with the psychosocial issues associated with myeloma, as much as I'm sure they would like to. They're very much here as the medical and nursing experts in myeloma and in Waldenstrom's. All right, this is now a free-for-all, open question and answer session to cover both diseases. And given that Professor Dimopoulos has been going non-stop, I actually might give him a few minutes pause and ask Professor Joshua here perhaps to start the thing off for us by perhaps reporting back to us the sort of questions that rose in your treatment-related side effects session, perhaps, Doug.
Thanks, Judith. So we had a session on side effects and we managed to get neuropathy discussed in our first session and we had quite a nice crowd for the first section. In the second session we had one person and we chatted to her about Albury and Wodonga and a few other bits and pieces. But I guess And yes, we suggested glucosamine because she's. But I guess the main issue really related to the reversibility of the neuropathy and how many patients have reversible neuropathy, what you can do about it, and how to control the symptoms of neuropathy. So if anyone's got any questions about that, I guess we'd be happy to take it now.
Because I think that's a really great thing to start up with, Doug, because I don't know how much neuropathy was discussed in the Waldenstrom session, Glenn. Was that discussed much? Do any of the patients with Waldenstroms have any particular questions about peripheral neuropathy?
Just one question. What's the treatment? At the moment I'm taking Lyrica. Is that just
Yeah, that's pregabalin, isn't it, Doug? Yeah. Do you want to?
So the medication you're taking is actually a painkiller to help manage the pain that has been caused by the neuropathy. It's not actually a treatment. So at this stage, there are no treatments that actually target that manage neuropathy. There are treatments that help manage the symptoms of neuropathy, and our main focus on managing neuropathy is trying to prevent it by dose reducing the agents that may contribute to causing it. So in myeloma, that's principally thalidomide and Velcade. So identifying the signs and symptoms early and grading it and changing the treatment and the dosing appropriately to stop it getting any worse. And then the management is focused on managing the symptoms of neuropathy. Yeah.
Yeah, and I should sort of preface my comments about the similarities between neuropathy and myeloma. The neuropathy is far more commonly treatment-related, whereas in Waldenstrom, it's far more commonly disease-related. So, Meletios, have you got perhaps had a moment to catch your breath, and would you like to make a couple of comments about neuropathy?
Well,
let's see if the lapel works.
You know, as you mentioned, in Waldenstrom's it can be related to the disease, so you need.
Use your handheld, please.
We're going to have to use the handheld.
Okay.
Sorry about that, folks.
Yeah. Well, when it is related to the disease, you need to treat the underlying cause. I mean, to reduce the levels of IgM. And there are some trials with rituximab. There are some mixed results. There is a small randomized trial which was not very positive. But depending on the severity of the peripheral neuropathy, one may even want to introduce more aggressive therapies. There are, for example, patients who have needed a treatment like FCR if peripheral neuropathy is also developing a motor element, not only a sensory defect.
Okay, now what I've decided to do is to put the 2 roving microphones at the front, because we can actually hear you quite well. So when you do ask your question, I'll repeat the question for the benefit of everyone else in the room and for the people online. So what topic would you like to move on to next that perhaps wasn't covered in any one of the sessions you've attended today? Philip.
a lot of people think I'm totally nuts at this time.
So,
But to me, my thought process gets a little bit confused.
so can I, Philip? Yeah, can I summarise that, since you and I share the problem of your steroid side effects, and it's a real challenge. So for the people online, Philip has asked about steroids and about the great feeling he feels on the couple of days, the high effectively he has on the couple of days after he's had his weekly dexamethasone, and then the real downer that he has in the subsequent days with the nausea and the giddiness in the head. Perhaps, Tracy, steroids are your particular research interest. And as a nurse who sort of counsels the patients about the side effects of therapy, perhaps you could comment on this first, and then perhaps Doug or Meletios.
Thanks, Judith. And it's hard to answer it very quickly, but certainly corticosteroids can upset a whole range of different, or can impact a whole range of different mechanisms within the body, including the causing a range of what we call neuropsychological effects. So they can alter your mood and your cognitive ability and energy, as well as having effects on various physical parameters within the body, that gastric, nausea, etc. So certainly they're a drug which can be hard to tolerate, and also not easy for us to measure the side effects easily, because we don't have a tool such as with neuropathy. We can measure the sensory neuropathy with tools that we have. So we do rely on you being able to interpret and describe to us what can be quite hard aspects to describe, such as I just feel down or up or mood, and you might not associate them with the steroids. So we certainly know they can be hard to tolerate, and we have to dose reduce very readily. The ups and the downs are very common in terms of energy ups, but also mood ups and mood downs. And also the effects of the steroids can often come after several days after you've taken the drug, which is somewhat counterintuitive. We certainly play around with the dosing, and it would sound to me that reducing the dose and playing around with the time at which you take your steroids might be useful, but also instead of taking one pulse of a dose of steroids, such as 10 tablets one day a week, that it might be worth choosing a scheduling of taking, say, 3 steroids, 2 steroids, 1 steroid, and taper them over a few days to allow for some improved tolerability. But it resonates with me, everything you're describing, and I don't think it's an easily fix. It's somewhat understandable, because we all produce corticosteroids normally, and they have a role in many checks and balances within the body, and we give them readily because they have an anti-myeloma effect. They're a principal part of the treatment. They can help improve the effects of the other drugs you're taking, but also do have an anti-myeloma effect themselves. So they're certainly very important drugs, but the whole range of side effects means that we very readily have to reduce the doses of that, or find different ways of taking them. So I would think a tapering dose over a few days rather than sticking to the hard and fast would be a way to go.
That's a bit tricky when you're on a clinical trial.
Yes.
When you're hoping that you get randomised to the arm that doesn't carry on with the steroids, for sure. Meletios, what's your approach to the patients who really suffer with the steroid side effects, other than dose reduction?
What we do is in these cases, we recommend for the next 2 days to get a small dose of prednisone, such as 5 milligram twice a day for the next 2 days. Because you see, on the other hand, if you start with dexamethasone, let's say, you have to give 40 milligram. If you start doing like 20, 10, 5, then you run into a continuous exposure, because even 5 milligram of dexamethasone is quite a high dose, and it has a long half-life, so you end up having a continuous exposure of the patient. Whereas with prednisone is short-lived, and sometimes with 2 days of low-dose prednisone, some of these effects may improve. Doug, what do you think?
Sorry.
I don't think it is. It lights on, but there's nobody home, so it's
Nobody. There we go.
Look, I would like to echo, and Joy, I guess will echo what what you've been told. We often use tapering doses, often use prednisone, and sometimes even have to split the doses up so that they're taken twice a week instead at reduced dose, of course, instead of taking. I think the important thing about steroids is it has multiple effects, and it can have very severe psychological effects, and they're often noticed and complained to by the carer rather than the patient. So the carer, I mean, just being argumentative and stroppy and crappy is often not something the patient will appreciate that he or she is, but the spouse or the partner will very readily appreciate that there's a change in psychological behaviour. And I think it's a very important thing.
I think
Some people can actually get psychotic, truly psychotic on steroids.
I think that's a very important point, and also the point about be careful when you're driving on the days when you have steroids. So, sir, your question.
Sorry, what was the tapering dose of prednisone? Did you say over 2 days or 4 days, or what are you saying at the moment?
If the withdrawal effect is not very severe, it can be abrogated to a certain extent by giving prednisone 5 milligram in the morning, 5 in the evening for the 2 consecutive days after the dexamethasone pulse.
Okay.
When the patient is getting the weekly dexamethasone, which is the usual way that...
Prednisone as well.
Right, yeah.
What about at the moment is taking 4 prednisones for 4 days? 4 prednisone a day for 4 days.
Well, this is
Or should
a
it be
different...
tapering? Would it be better to taper it?
Could be.
Could well be. So perhaps we'll move away from steroid side effects, and has
Judith,
anyone else?
I was just
Sorry.
going to very
Joy,
quickly
please.
raise the
Yes.
issue of 40 milligrams dex versus
Yeah.
20 milligrams
Yes,
dex in the
please.
sense of the Mayo Clinic study, which is quite some time ago, where they showed that with Revlimid that the high dose dex actually was not as good. It's good because of the toxicities. And I'm interested in what Thanos feels, because I must say for older people with the weekly dose, I really never give 40 now. I actually tend to give 20. And even in the younger people, I tend to give 20 rather than 40.
Yeah,
Mm.
I agree.
Absolutely. Glenn, would you like to ask a question?
Yeah, in the Waterstrom sessions, we've been hearing about the viscosity of the blood and the effects on the circulation system. Is there any relationship that we know about between, say, Waterstrom's or the various chemotherapy treatments and memory loss and onset of early dementia? That sort of thing?
Oh, now who's going to take that curly question? Doug's the one holding the microphone that's working.
I'll start us off gently in terms of, and then we'll move more medically. Because it's probably worth mentioning this concept of chemo brain. So, which is a term that's used readily in the support services in cancer, and really talks to the ability, the loss in short-term memory when people make a diagnosis of a cancer and are on treatment. And we commonly call it chemo brain, but it really refers to during their whole experience with an illness and a cancer and treatment. And I don't think the mechanism is so much linked to the medicines themselves, more so the context in which you find yourself, diagnosed with a considerable illness and moving in and out of very complex, busy health systems. But that'll start us off with an explanation of chemo brain. But in terms of the relationship specifically between the medicines and cognitive function, I'll pass on to my medical colleagues.
Look, I think this phenomenon of what's called chemo brain, but really refers to, especially in high-functioning individuals, the inability to function at the same level, and even in ordinary, ordinary individuals, the ability to function at the same level as you were functioning when you're having active chemotherapy is difficult. And I think a lot of people complain about it, and it's especially if people are running businesses or, I don't know, teaching or something that requires quite a high level. They find that quite difficult. What it's due to, I don't think we know. In Waldenstrom's, I'm not sure whether the question was, can hyperviscosity or can very high proteins interfere with cerebral function? They certainly can if they're very high, and that's why we plasmapheresis people, so people can present unconscious and wake up during a plasmapheresis. It's really quite a dramatic thing when you see it happen, and most of us would have seen it happen sometimes. So yes, I mean, hyperviscosity can impair function, but I think that's an acute situation, and I think quite different from this this chemo brain, or whatever the right term is. I mean, this has been described in not only in adults, the children who have acute leukemia and get chemotherapy and often get treatment to the central spinal or cerebral treatment. They definitely have difficulty in mathematical functioning as they get older. It seems to be more so in a mathematical situation, but I guess in an adult they don't have to do calculus, but it refers to their functioning of their lives and business and whatnot. So I think there is a real factor there. I don't know that we know it's due to any specific drug except radiation, cerebral radiation. If you happen to have your brain irradiated, there's definitely a cognitive defect that develops, but it often takes a number of years. So while we avoid irradiating young people, if someone has, not related to Waldenstrom's, but if someone has a cerebral tumour or something and gets irradiation, it's much more acceptable to offer that to an older patient than it is to a younger patient where you might try some other mechanism.
So perhaps I'll close that discussion up by actually noting, Glenn, that you have probably developed the best therapy for the subtle memory losses, and that you come to clinic with a pen and paper. And can I encourage you all to do that? Because even those of us with the best cognitive function can only ever, apparently research tells us, remember, 10% of what we're told by our doctor in the clinic. Next question. The lady at the back with the blue, if you could speak loudly. I'm sorry, our roving microphones are not working well, but I'll repeat the question. We can come back to you.
No. It was a much broader question. It was about, is there any evidence about the role of sugar in this disease? And to go with that, are any of the complementary therapies helpful, like having massages or meditation, those sorts of things, that they have been observed in a reasonably scientific
Okay.
level?
Perhaps I can make a comment about that while my four colleagues, perhaps Joy, you can think about an answer to the sugar question. Certainly complementary therapies are just that. They are complementary to your medical therapy. They are not medical therapies. But I think they're therapeutic in helping your sense of well-being and your sense, in the way a massage helps all of us, and in stressful times, and certainly being diagnosed with myeloma and Waldenstrom's and going through therapy is very stressful. I think they help you also in giving you a sense of control and doing things yourself rather than just being the passive recipient of the medicines that the doctor is administering you. But I am not aware, and I'm happy to be corrected by any of my colleagues here, that there is any proven alternative therapy that actually improves treatment of myeloma or Waldenstrom's.
Well, I guess to answer your sugar question first, it would be fair to say that we get asked questions about various nutrients almost every day, not every other day. Even today, I was asked by a patient in my small group about iron, and that lady feels that she believes that iron's feeding the cancer, and therefore she avoids, she's vegetarian anyway, but that's one of her reasons for avoiding iron. And in the similar way, you've asked a question about sugar. So my stand, I think I would be very frank in saying that because information is so easily disseminated, you can read a lot of things without really knowing the source and the amount of experimentation that has gone into writing that type of information. I don't know of any particular clear evidence that sugar or indeed iron feeds the tumor. I can only say with a lot of these nutritional questions, you've got to be sure that you're not depriving yourself of an essential nutrient in your health that may in fact adversely impact on your general health and therefore your ability to fight the cancer. With respect to complementary therapies, we again ask these questions all the time, and you know, I guess in the last 18 months we get asked a lot about curcumin, and we get asked about, and I'm not in no way telling you to go and buy a bottle of curcumin, but you know, there are various bits of information that proliferates mainly in the nutritional health type literature, and I think my main advice is, you've got to be sure. We as your doctors are in no position to tell you what to do, but we can only advise you in the best way possible. And you've got to be sure that what you're taking does not counteract what we are advising you to take as far as the treatment you require. And in addition, that when you seek to believe a source of information, you should check it out, because there is a lot of misinformation in the internet.
Can I just follow up with two good resources that I would signpost people to here in Australia to support the need to really make sure that in this day and age of ease of Dr. Google and the use of the internet, which is an evidence-based resource, that there are two places that I always signpost people to. One is iheard.com.au, which is from the Cancer Council here in Australia, which is a place where a web page that you can go to and pose these questions, such as I heard sugar feeds cancer, and a group of scientists and health professionals will address that question with an evidence base. And the sugar one is already on there. It's under frequently asked questions. So you can go there and see if there is any evidence to support or not, it will be there. The other one is an app or a website from Memorial Sloan Kettering, where there is an integrated medicine approach there, where medicine and science looks at the role of complementary therapies, particularly supplements and things that you've just answered. And there's an app called About Herbs that you can download from the App Store, or go to Memorial Sloan Kettering website and navigate to About Herbs. And that again is an evidence-based information resource for you to look up any supplement or any complementary therapy, and it will put the evidence base for its benefit, its lack of benefit, or any interactions with other medicines. So two great resources but you do need to be very, very cautious in this day of ease of Googling anything. Know where that information and that answer comes from.
Thank you very much for that, Tracy. Perhaps
I'd just like to ask something about the genetics. What's been studied in research about is the links in genetics such as is it being passed on in families? What research has been done about that?
Okay.
For people like me who, if I have myeloma, do my children, should they get tested?
Perhaps I could ask Professor Demopoulos to answer that question. Would you like to answer it from a myeloma perspective, and then for the Waldenstroms as well?
Yeah.
Thank you.
Okay, for both diseases and a little bit more for Waldenstrom, there is what we call a familial predilection. It's not like you have a gene, like some cases of breast cancer, where you can describe a familial form of breast cancer. But, for Waldenstrom's, maybe the relatives have a 3 times higher probability to develop it. But always keep in mind that Waldenstrom's develop in 1 in 100,000. So even if you increase it by 3 times, it's still very rare occurrence. And of course, I am against doing any type of screening electrophoresis in relatives of patients with myeloma or with Waldenstrom, because even if you detect it, there is nothing that you can do. And we have found out that it is a source of anxiety for the person who was found to have the monoclonal protein, and also for the whole family. I don't know, Doug, what is your opinion on that.
That's absolutely right. There is a familial predisposition especially in Waldenstrom's, much more so than in myeloma.
So just a little bit louder.
Sorry, much more so than myeloma, but we don't screen family members, and I think you can reassure children that the likelihood of them developing myeloma is extremely rare.
They're still more likely to get breast cancer, colon cancer, lung cancer if they're smokers. So,
What's the significance of iron studies in Waldenstrom's?
So the question has been, what is the significance of iron studies in Waldenstrom's? Sorry? Iron. I would, while they're all thinking, I would say the only reason I would do iron studies in someone with Waldenstrom's is when given that the vast majority present with anemia, I need to exclude coexisting causes for the anemia rather than just assuming it's all due to the Waldenstrom's. Joy, would you like to add any comments to that?
Nothing really much to add. It's precisely that indeed we actually talked about that briefly in the myeloma session on anemia just now. That of course myeloma, for instance, is the most important cause of anemia in most myeloma patients, but sometimes patients are anemic for other reasons, and that would be the reason to check out that they are not deficient in iron. It's rare, in fact, if you're thinking about doing iron studies to test for iron overload in patients who are recurrently transfused, it's in fact quite rare and really not appropriate to do iron studies in these two diseases, unlike in a number.
Gynecologist on one of the tests for
Yeah.
the iron studies, and also a B12.
Okay, so it's quite possible that he did that because you were anemic, is that correct? Were you anemic?
Not really, not at the time.
Okay.
Just one of these tests that he
Yes.
signified, and he
Well,
had B12 on the next one.
I see. So I suspect that he may be wondering whether you have alternative causes of being a little low on the red blood, and just wanted to make sure that he didn't need to give you some supplementation in addition to treating your myeloma.
Okay.
It's
Your Waldenstrom's. Yep.
So, sir, in the back, you've been very patient. Thank you.
I just need to know what the panel's consensus is on the upper age limit stem cell transplants where it's no longer recommended for bowels.
Okay, so this is a question about the upper age limit for stem cell transplantation. Who would like to address that topic? Doug, I think you and certainly Meletios certainly discussed it in the.
Well, it is a biological age. I've certainly personally transplanted someone up to 75, which would be the oldest that I've transplanted. But this was a remarkably fit man. He was a mountaineer, so he was at 75. He was climbing up mountains. So I think it is a biological factor. It really relates to other illnesses that people may have. There's certainly people who are age 50 who would not be suitable for transplantation if they've got severe ischemic heart disease or something. So it is a biological question. But the clinical trials, the value of 65 comes about from the clinical trials, which basically excluded people over 65. So we have clinical trial data up to the age of 65, and we don't have data after the age of 65. But it is certainly a biological issue, and there's certainly people in their, 65 to 70 who would benefit from transplantation, who are fit and well and active, and there's no reason why they shouldn't be transplanted.
And given, I think Professor Demopoulos would echo those sentiments, I think we'll move on. Sir.
Yes, I have a question for the panel. In Waldenström, the IgM production is so high that it suppresses the IgA and IgG. Is there all, at the moment, monthly infusions of intragram are given to the patient? Are there any drugs or hormone treatment that is also effective?
I think the simple answer is effective treatment of the disease is the only thing that may improve the immunoglobulin levels. But Meletios?
Well, I think the only indication for a patient to get intravenous immunoglobulin is not the low levels of the uninvolved immunoglobulin, but only if there are recurrent infections. I don't think that it is appropriate to routinely administer IVIG in a patient who has, let's say, 1 or 2 infections a year. I mean, because of uninvolved immunoglobulins. I don't think that this is a good practice. There have been trials in CLL in the past and in myeloma, small trials, that really they don't show any beneficial effect of doing that. Oftentimes, the low levels of uninvolved immunoglobulins may remain low even if the patient has responded to treatment. Sometimes for patients who have a very good response and who do not get a very immunosuppressive agent, then you will see some kind of recovery. But if you get, let's say, a nucleoside analog, you won't see that.
And I should echo that in Australia we are not allowed to, neither should we, prescribe intravenous immunoglobulin replacement therapy in the absence of recurrent infections for patients who have low immunoglobulin levels. Okay, at the back, please speak loudly.
What about reducing the protein level that you eat to reduce the IGF-1? What's your view about that?
So reducing the protein in your diet to reduce the IGF-1 levels. Now, I think everyone's shaking their head here. I can't see how reduction in protein intake would reduce your IGF-1 levels.
Switches the genes off and on. And I was watching a video when I was on the airplane going overseas, and Michael Mosley was talking to a scientist, and they were doing tests, and the lower the IGF level, it reduced the turnover of cells, including the cancer cells, and the blood that was put onto the actual cancer cells with the low IGF-1 level, it reduced the movement of the cancer cells, whereas the other one, they were prolific.
Yeah. I think there's got to be very cautious. Joy, I think you're going to respond to this.
Doctor lecturing the big Victorian on the internet about the different causes of death, and he said that having a lower IGF level reduced a lot of causes of death, including cancer.
So we had a discussion about sources of information just now, and I was speaking to the lady in blue just now, and I don't think I didn't see you at the back, so you probably missed my answer there, but I'll take this on. I'm sure my colleagues will probably echo my answer. Again, it's an issue of the source of information, but secondly, what you apply from basic research to what you actually do practically and clinically. IGF-1 is a well-known tumor growth factor, not only for myeloma, but also for many other tumors. Just because there is basic research indicating that reduction in total protein reduces IGF-1 and therefore reduces motility of cancer cells, in this case it seems like you're talking about myeloma cells, in animals or in Petri dishes, doesn't mean that we can immediately then apply that information to patients. Indeed, the restriction of protein in a patient may very well be detrimental along the same lines as I just talked about sugar and about iron. So I can say to you, unless I am deficient in the information on IGF-1, that I would clearly would not advise restricting your protein intake, because that will in fact be detrimental to your general health to attempt to reduce a growth factor for which there is no particular reason in knowing that it will be effective in reducing the growth factor. There's no clinical trial stating that in patients it will be helpful, and secondly, that in doing so it would actually defeat the myeloma.
And may I say that there is no greater Australian authority on IGF-1 than Dr. Ho.
I don't think so. No, I just
So we might finish up there
not at all.
with just one final question before I invite Professor Beale, and you were the lucky man who put his hand up first. Go ahead.
Right. I've recently learned that there has been very promising results of this trial of a new drug in Melbourne, which is the MDX1097. I just want to know more about it. At what stage is it in now? Is the trial going to be extended to New South Wales? If so, how do I participate?
Promising results with MDX1097. Is that might be the antibody, the light chain antibody, is it? I think that's Andrew Spencer's study on one of the light chain antibodies, and yes, we were very keen to participate in this study at Concord, and then for some reason we were no longer invited to do so. I'm afraid, sir, we are not yet aware of the exact details unless any one of you can remember.
Yeah, I'm just aware that a patient of mine did go to Melbourne to inquire about it, and at that time it was phase 2. So, and that was only a year ago. So I'd be very surprised if it's gone to phase 3 already.
Yeah.
Is it phase 3?
I'm not aware of any expansion trial in that. So they're probably waiting for longer term follow-up from the phase 2 data before then they decide whether they will advance it into a phase 3 setting, which, as we discussed before, is the trial where you're comparing adding this antibody with what would be standard therapy for myeloma. So perhaps I might just ask Professor Demopoulos, if you had to choose one antibody, which one would be the goer for treating myeloma?
Definitely anti-CD38.
Anti-CD38, all right? And CD38 is a protein expressed on the surface of just about every single myeloma cell in every single myeloma patient. So thanks for giving us that tip. We'll make sure we try and get an anti-CD38 antibody study either here at Concord or at Royal Prince Alfred Hospital, and hopefully in any one of those hospitals that are conducting clinical trials close to where you are being cared for. And on that note, I would like to thank very much my 4 guest panellists. Perhaps you might just like to wait there while Professor Beale comes and gives us his closing address. Thank you very much for your valued contribution.
We seem to have one last question.
I thank everybody that's involved in putting this on, and the positive of all the people that are involved and the research. Keep up the good work.
Thank you.
Well, you've stolen some of my words, but they were very well spoken, and I think indeed I could feel it from the heart, and I could really sense it in the room that was the feeling here, and I really do think that I was really enjoying the questions that were being thrown out today. I'm glad I wasn't actually on the couch though, having to answer all of them, because some of them were a little tricky, but I think that reflected everyone's clearly thoughtfulness and interest in this area. I think it's been a great day for Concord Hospital, for the Concord Cancer Centre, and indeed for the district-wide in terms of this symposium here today. I think it can sense that everyone has both enjoyed it and benefited from this, and I think there is great thanks to those who've organised that, and I'll say a few more words about that. I just wanted to reflect just very briefly on the Concord Cancer Centre and what it really means, and I think that it was launched about a year ago in September, and it really was the thought that we would want to bring all of the skills that we have here on this campus and indeed beyond this campus to provide the best patient care that we possibly could, and to really focus on that as our central point, but then to work on the things that we think, how can we truly improve this and work on it to make it the best place to provide care for patients who have a diagnosis of a cancer. And so I think that that has been our central point, and we've been looking at ways that we can bring people together. We can bring resources together here within the hospital to look at the environment that we have and to look at where we actually both treat patients, where patients are cared for in the ward, and indeed beyond into areas including survivorship, whereby we are now looking at ways to think of things such as chemotherapy brain, such as fatigue, such as the psychological issues that are raised by a diagnosis like this, and indeed the treatments that are actually given. And we are now moving very much towards those and fulfilling hopefully some of those goals. I think, however, there are other things which are equally as important. That includes research, and I think, again, you've been hearing about that, and the research that is being done both here and around Australia, and indeed around the world, I think are the things that we really want to draw upon, and to both improve what we can do, but also then to be able to apply it and to actually offer that information to all of you. And I think that people like Judith, in her role in terms of being a clinical trial investigator and an advocate for bringing trials and opening trials, is something which I think we greatly appreciate here at this hospital, but indeed those collaborations, as I say, go well beyond that and around Australia, so that we can actually bring the best trials. In addition to that, there's the research which is going on in our laboratories, which are both here and at Prince Alfred, at the Centenary Institute and the University of Sydney. And those collaborations are also equally important, I think, in understanding about the nature of these diseases, so that we really can unlock some of those keys to how we can find better treatments and newer therapies, such as the ones maybe that were being discussed, and I think the ones that might have been advocated. And all of this requires sort of a coordinated approach, and we've been sort of really have been well supported, I think, through the hospital and through the district and the university to actually help with a lot of these processes. We've been lucky here today that we've had both we've had this symposium on here, and next door we've had another symposium to do with asbestos diseases, and that is also just a reflection of the environment that actually is on this campus and within the university, both in terms of research and academic interest, but providing always the idea that we can provide best patient care. So I would also like to close by really thanking Judith in particular for her sterling effort both in this symposium, but also there is a small event tonight which will be a small soiree, which I think will also be an important event for both celebrating but also some fundraising for these purposes, and I think that's great. And I think all the other speakers too need to be thanked for their contribution and their time. I think it really has been a great day. So I'll close on that and say thank you once again.